This is the sixth pilot module in Nebraska's training for staff members working in lead poisoning prevention. This module will help new staff members better understand how their work ties into the general goal of prevention. It can also help serve as a refresher for staff who develop educational campaigns related to screening. And finally, the information on appropriate testing techniques may help in direct outreach to healthcare providers and laboratories. Here we will focus on the strategies to improve screening for exposure. In the next module, we will talk more directly about communicating with healthcare providers. You will need internet access to view the video included in this module. You will also have an opportunity to view more information on specific topics by clicking on the links shown in the slide. Return to the module after viewing these links. Slides will automatically advance with the narration. If you wish to move more quickly, right-click to advance to the next slide. Early in the module, you will see a link to a pretest. At the end, you will see a link to a post-test and evaluation. Please complete both before you exit this module. In this module, we will review some of the state's definitions and policies, recommended capillary sample collection practices, and strategies to improve compliance with testing requirements. Our goal in this module is to help you communicate with healthcare providers and families about why testing needs to occur and when. Changes in blood lead levels indicate whether all sources of exposure are being addressed. It is the best way to ensure that medical and other management strategies are successful. Now take a minute to complete the pretest. When you are finished, return to the module. The only reliable way to know whether a child has had a significant exposure to lead is through a blood test. These tests can be collected for screening, confirmation, or follow-up. These can be either through capillary or venous collection. A screening test is the first blood lead drawn on a child who has not been tested and is under 72 months or 6 years of age. This could have been collected through capillary or venous draws. The sample should be analyzed at a laboratory that meets the standards set by the Federal Clinical Laboratory Improvement Amendments, or CLIA, or it can be analyzed at the point of care with a portable device specifically approved for this purpose, such as the LeadCare 2. It is important to remember that responses to the risk assessment questionnaire administered in a healthcare provider's office are not screening tests. Sometimes people confuse the two measures. As we discussed in earlier modules, in Nebraska, local public health responds to a positive blood lead level at the point a confirmatory test has occurred. Until then, the case is considered a suspected EBLL. The confirmatory test is a second test, preferably a venous draw, whose results are at or greater than 5 micrograms per deciliter. Capillary samples should be used to confirm only in limited circumstances. Nebraska sets 3 criteria for screening based on age, consistent with the CDC guidelines. These are location, Medicaid status, and response to the Nebraska Risk Assessment Questionnaire administered at the healthcare provider's office. We will focus on these criteria in the next slides. As we discussed in the first module, cities with a high percentage of older homes have a higher risk to exposing children to lead. The state CLIP has identified zip codes in the cities marked with blue stars as locations where children should receive a screening test regardless of their parents' response to the risk assessment questionnaire. You can click on the link to see the full testing plan. The state CLIP strongly recommends that all children living in these communities be tested for lead poisoning at both 12 and 24 months of age. Children between 25 and 72 months of age need to be tested as soon as possible, if not previously tested. Targeted communities may change as more blood lead data is obtained. The Kaiser Family Foundation reported 13% of Nebraska's population was covered by Medicaid or the Children's Health Insurance Program, or CHIP, in 2017. 1/4 of all children in the state were covered by Medicaid. This means that a significant number of Nebraska's children should have blood lead tests at ages 1 and 2 or be screened at ages 36 to 72 months if they have not had one in the past. We know that risk assessment questions are important in identifying children who may need a screening test, but they have limitations. In 2016, research on a set of similar questions showed that they had a 26% sensitivity, which means that the test could correctly identify children with elevated blood lead levels about 25% of the time. The questionnaire had a 72% specificity, meaning it could correctly identify children that did not have them only about 70% of the time. This means that we should be cautious in assuming a blood lead test is not needed if the response to the risk assessment questions are negative. The last risk assessment question, highlighted in yellow, is important. As we showed in an earlier module, Nebraska has more ethnic diversity than you might expect. CDC has found that newly arrived refugee children are twice as likely as U.S. children to have elevated blood lead levels. Country of origin and country of departure to the U.S. can increase the risk of arriving with an elevated blood lead level. This means that screening needs to be done soon after arrival to identify children and pregnant women at risk. In addition, refugee children are at risk for elevated blood lead levels after resettlement in the U.S. Refugee Resettlement Services provide assistance for 3 months following arrival. After this, the families are on their own. They may initially have been placed in housing with deteriorated lead-based paint, or they may move to new homes with this risk after resettlement services end. Risk factors for elevated blood lead levels after arrival include living in older homes, presence of lead hazards in the home, cultural practices and traditional medicines, lack of awareness of the dangers of lead, and compromised nutritional status. This makes repeat blood tests a medical necessity. Children with refugee status are eligible for Medicaid for at least 8 months after arrival in the United States. CDC has provided a toolkit with additional guidance on working with refugee populations. It also has additional guidance for families who are adopting children from overseas. Click on these links to see more. We normally talk about blood lead screening in regard to children, but there is one exception: pregnant women. Nebraska encourages following the CDC guidelines for pregnant and lactating women. Lead can cross the placenta and interfere with brain development. Because lead is stored in bone, women who have worked with, have a history of an elevated blood lead level as a child, or have other significant exposures or nutritional deficits may have higher blood lead levels when bone releases lead into the blood. High levels of lead during pregnancy can cause miscarriage, stillbirth, lower infant birth weight, and premature delivery. They can also be associated with risks for preeclampsia for the mother. Lead can also pass into breast milk. This means that any pregnant or breastfeeding woman known to be at risk for lead exposure, or those who have recently moved to the U.S., should be tested for lead. Click on the report image for more information. Given this source of exposure, you might ask, why doesn't every pregnant woman need a lead test? CDC does not recommend universal screening because the benefits do not outweigh the potential harms, such as false positive test results, anxiety, inconvenience, work or school absenteeism, and the financial costs associated with testing. CDC also recommends that women with blood lead levels of 45 or greater be treated as high-risk pregnancies. Instead of universal testing, CDC recommends that public health departments identify populations at increased risk. Clinics serving women with specific occupational, environmental, or lifestyle risk factors for exposure may want to perform blood lead testing if any of these risk factors are identified. Assessment for lead exposure based on the risk factor questionnaire or blood lead testing should take place at the earliest contact with the pregnant woman. CDC also recommends that women with blood lead levels of 15 or above should have home environmental inspections and the hazards remediated. CDC recommends that mothers with blood lead levels below 40 micrograms per deciliter continue to nurse because breast milk contains important nutrients, strengthens the infant's immune system, and increases the maternal-infant bonding experience. It recommends that mothers with blood lead levels of 40 or greater discontinue breastfeeding until the levels drop below 40, but continue to pump. Breast milk should be discarded until blood lead levels decline and they can restart nursing. So if you are asked what to do with a child under age 2, what factors would you consider? Location, Medicaid status, possible exposures to the home, or maternal histories of exposures? What factors would you consider? The first 3. Nebraska policy requires consideration of the child's location, Medicaid status, and responses to the risk assessment questions. In general, by the time that a child is age 2, the mother's own blood lead status is not likely to influence the child's. There is one exception. If the child is still breastfeeding, if the mother has an EBLL of 40 micrograms or greater, this could be a risk factor, one that should be taken into consideration if children's tests at ages 1 and 2 are positive. Let's focus now on best practices for sample collection. A false positive means that a positive capillary test at 5 micrograms per deciliter has a venous confirmatory test with a lower value. This comes from poor technique or contamination of the materials used to collect the sample. False positives increase the workload of your program and can lead to families' mistrust of the results of testing. Although you may not be involved in collecting samples, you may need to educate others at healthcare provider offices or other settings. This may become an important educational outreach activity for your program. Those collecting the samples may have to adjust their practices. This would include taking special care to clean and cover surfaces where the collection occurs. Use supplies labeled as lead-free. Draw the sample for lead testing before other samples. Thoroughly clean the child's hands, then let them air dry. Discard the first drop of blood before starting to collect the sample, and don't wipe the site before collecting the next blood drop. And finally, never touch the collection tube to the skin, only to the blood droplet. This CDC video shows the proper techniques in detail. If you want to watch this now, click on the video logo and advance to minute 7.49. The video will take about 10 minutes. We have also provided the link in case you wish to view this later. This could be a good tool for outreach to medical providers and their staffs. A special note on using machines to analyze capillary samples while in the field. These are called point-of-care analyzers. The most commonly used brand is the LeadCare system manufactured by Magellan Diagnostics. Point-of-care systems make it convenient to give the family the results of a blood test without the delays that come from sending the sample to a lab for analysis. The accuracy of the test result depends on using proper procedures for collection and understanding the margin of error for the machine. These machines cannot reliably detect blood lead levels under 5 micrograms per deciliter. Programs should never analyze venous samples with a point-of-care analyzer. Confirmatory venous samples should be tested at a CLIA-certified laboratory. If healthcare providers use a point-of-care system for blood lead screening tests, they must report all test results to the state CLIP. This is something your program may need to emphasize in outreach to providers. Venous confirmatory tests need to occur at different times depending on the value of the initial screening test. If under 5 micrograms per deciliter, there is no requirement to confirm. At or greater than 70 micrograms per deciliter is an emergency and needs immediate confirmation. So which of these statements are true based on what we just reviewed? Take a minute to look at these in detail. So which of these statements are true? None of them. A sterile technique is not sufficient for collecting lead samples because the materials that are used during collection could be contaminated by lead. Point-of-care analyzers should never be used for analyzing confirmatory tests. Finally, Nebraska policy requires that capillary screening tests of 5 micrograms per deciliter or greater be confirmed by a venous test. Let's move on to strategies to improve screening and confirmation. We know that screening rates are low in many states, even though there are national and state policies for testing. Keeshan's study looked at physicians' own explanations for lower screening rates. Not surprisingly, they cited parental opposition and lack of compliance as major factors, as well as negative responses to the risk assessment questionnaire. The burden on staff and the difficulties of collecting a sample during the visit also played a role. But when the surveys were analyzed by the type of respondent, women providers who were aware that blood leads below 10 had negative effects, and those who had 55% or more of Medicaid recipients in their practice were more likely to order a screening test. Knowing the testing rules, however, does not automatically lead to action. Kemper and Clark's survey of physicians found that physicians who knew Medicaid testing rules still misperceived how the rules applied to their practices, with 35% who were in high-risk areas thinking they were in low-risk areas. Feinberg and Cummings' chart reviews of Medicaid-eligible children found that the practitioners overestimated the number of children they had tested, even controlling for cases where parents did not follow the instructions to get the test. Keep these misperceptions on testing in mind when you are doing outreach to healthcare providers. You may need to correct some of them in order to improve screening rates in your communities. Parents also misunderstand why tests are ordered and what they mean. This applies not only to screening tests, but also to parents' willingness to follow the confirmation and follow-up test schedules. The researchers in this study found that parents concerned about the testing process, not wanting their children to experience more painful tests, and not understanding the billing process contributed to their reluctance to test. Sending parents to testing locations that are hard to get to or whose hours are not convenient for their work schedule decrease their compliance. Finally, information that was too technical or that required a higher level of literacy was also a barrier. Even though you may not actually do blood lead testing, your program is instrumental in improving screening and follow-up. Making sure that all the local service providers know and follow the testing requirements is a start. Your program may be able to piggyback on WIC requirements for tests for iron deficiency. One way that some communities across the country handle this requirement is to do blood lead testing at WIC sites where they do their hemoglobin hematocrit testing. This is a place where a point-of-care analyzer might be useful. Healthcare providers might not know when laboratory test sites are open or their locations. If your program can identify the testing sites and hours of operation in your city or county, this might make it easier for families to comply with testing. In-service training at clinics and provider offices, at least yearly, could assure that everyone has the right information. Healthcare services have a lot on their plates, so repetition is important to be sure the message is clear. A laminated copy of the statewide blood lead risk assessment blood lead testing plan that could be displayed in provider offices could also help. Take advantage of opportunities to engage community organizations by sending copies of your educational materials to agencies, community, and faith-based organizations in target zip codes. Finally, October is Lead Poisoning Prevention Month. The work to educate the community is already done for you. You just need to use it. CDC, EPA, and HUD provide complete toolkits for working with community organizations, social media messages, and posters you can modify to include your program's contact information. These are in multiple languages. New Hampshire shares the same problem as Nebraska. It's a rural state, and outreach is difficult. When confronted with low screening rates, the state program undertook research to find the barriers to screening. They found first, venous testing had low compliance and resulted in costly follow-up time for providers, and second, lack of understanding in the medical community about the importance of blood lead testing led to low testing rates. After a one-year project to improve medical education, provide point-of-care analyzers, and make reminders for parents more effective, testing rates improved dramatically. They increased the most with face-to-face education for medical providers and when providers were given point-of-care analyzers. The best strategy for working with parents is to build a trusting relationship. This will take time and work on your part. Many of the families we work with may not get encouraging messages about how they parent. Sending a positive message when they do get the test, when the test results show improvement, and when they follow the other strategies for eliminating lead exposures helps build that relationship. Something as simple as a handwritten "good job" on the test results can mean a lot. If you don't have the time or resources to do this, is there a way you can work with others doing outreach to do so? Could you use student interns? Access to convenient testing sites will also help. Ask if families are having trouble getting to the testing locations. See if there are resources in the community to help with transportation. Your program is doing blood lead testing at a WIC office using a point-of-care analyzer. The mother of a 2-year-old asks why the test is needed. She's concerned about the pain her child will feel. So what can you tell this mother about testing? Think about these answers. It won't hurt. The test is free. This is a requirement for WIC services. She'll know the results fast. The last 3 are correct. A finger prick does hurt, but only for a little while. You can minimize the need for multiple finger sticks by taking the blood lead test first, then letting the WIC staff collect samples for hemoglobin or hematocrit testing. If your program has a point-of-care analyzer, the test should be free to the family. Since WIC must request that a healthcare provider or a lead program test the child at enrollment, this is making it more convenient to receive WIC services. But the strongest message is that the family will know the results quickly. This will also give you the opportunity to build a relationship with the family as you talk to the mother about next steps to address lead exposures. So what do you tell her about why the test is needed? No amount of lead is good for a child. The child's eligibility for WIC means that he or she is in a high-risk group. It is the only way to know if her child is exposed to lead. What do you tell her about why the test is needed? All of these things. On-site testing gives you the opportunity to really explain the risks of lead exposure. It also gives you an opportunity to help the family plan for confirmatory tests and keep track of children who need confirmatory tests. Finally, it gives you an opportunity to build an ongoing relationship with the family, which will be needed to ensure compliance with follow-up testing requirements. Here are some resources that you might want to review. The CDC's website contains a variety of resources on these topics, including videos, toolkits, and information for children. Take a minute to review these key messages. We hope this module has improved your understanding of ways you can improve screening and confirmatory testing. Please click on the link to complete the post-test and evaluation. Thank you.